Hello, my name is Linda Martell, and I'm going to share my screen so you can see my PowerPoint on the clinical teaching project plan. Again, this is my clinical teaching project plan. My name is Linda Martell. I'm an advanced registered nurse practitioner. In my workplace, providers alternate 2 days a week, seeing residents in a local nursing skilled facility. Our medical office does not have formal documentation protocol or a documentation template for our SNF residents. And providers are spending an enormous amount of time paging through the residents' charts. This is creating occasions when we fail to see or properly interpret vital information regarding follow-up care documented by the previous provider. Providers are documenting in styles of preference, resulting in inconsistent and difficult to follow, and sometimes missing critical information regarding resident care. Providers are frustrated, and they comment that they're too busy to address the problem. Appropriate follow-up on resident problems is putting safe care at risk and increasing hospitalizations. My description of learners are ages 27 through 55, gender male and female. Education level is master prepared through medical degree prepared learners. Primary language is English. Cultural considerations were not identified. There were none identified. The experience of the learners is 4 years to 35 years in the medical field, and technical skills range from electronic medical record proficient to the owner and operator who is actually resistant to technology. The goal was to educate the learners about best practice, evidence-based use of a uniform SOAP note at the skilled nursing home facility and achieve 80% compliance. My objectives were as follows. Number one, by the completion of the sessions, learners will be able to recognize 3 benefits of uniform SOAP note documentation. Number two, by the completion of the sessions, learners using the uniform SOAP note will be able to appropriately identify resident problem list 80% of the time. And number three, by the completion of the sessions, learners will demonstrate a resident visit and implement an approach that reflects evidence-based SOAP note documentation that fosters patient safety and decreases hospitalizations by 50%. My method of instruction was constructivism. I chose constructivism as my method of teaching this learner population. With constructivism, learning is seen as a collaborative role. The learners actively participate in the construction of their understanding. Reflection, experiential, and self-directed learning are key elements in this broad perspective, and that is a quote by Pugsley. My review of literature methodology, article number 1, was entitled Interpersonal Education for Students in the Health Professions, the Seamless Care Model. This was a level of evidence number 5. The educational model incorporated 3 unified intercessions with novice learners, expert learners, and patients. With this conceptual framework, one of the instructional approaches comprised of small group collaborative practice, experience, and problem solving. The measurement for this research article were both qualitative and quantitative in a planned mixed measured approach. The article concluded stressing the importance of interpersonal education, otherwise known as IPE. My second article was titled Constructivism in Cultural Competence Education, and this was an evidence level number 3, or evidence level 3. This article discussed the success of learning using constructivist learning theory. The article questioned whether perceptions, attitudes, knowledge, and skills improved after using this method of teaching. The article also questioned whether delivery method influenced change. Article number 3 title was Learning Theories, Application, and Nursing Education, Evidence Level number 7. While this article discusses many different theories, I felt the ability to compare theories and the article's descriptions of the effectiveness of the use of constructivist theory was very appropriate for the learning activity I'll be leading. The philosophy of construct learning theory is unique. This theory does not assume the learner keeps a version of their view of reality in mind during the learning process. This mindset allows for greater opportunities for students to be placed in situations and discussions that have varied perspectives. This promotes open conversations with participants and instructors to determine the amount of knowledge acquired. And lastly, my methodology of article number 4, a construct model for teaching evidence-based practice. This was evidence level 7. This article was by far the most interesting and, in my opinion, the most accurate regarding the learner's attitudes. This piece was descriptive of the many different studies that explored the constructivist learning model and why it is a successful strategy for learners. This article states, learning is strongly influenced by the degree to which individuals are invested in the learning process and is considered a tactic to educational restructuring. The article goes on to describe learners as open organisms seeking meaning, not just blank slates. Although this article is an evidence level 7, I feel the expert opinions and credentials of the scholarly writers was very valid and would even go as far as to recommend this article for review by the Frontier faculty as part of the PC 711 required reading. The articles I chose for the literature review had the same theme. Learners build on their own knowledge base. Learners incorporate new learning, and the studies required active learning exercises. This plan fostered the participants' occasions to reflect and construct knowledge and understanding through social compromise and relationships. The Constructivism and Cultural Competence Education article used a quasi-experimental study to test constructivism for competence in cultural education and if the delivery method influenced the degree of change. The following shows significant change with a P-score of less than 0.001 in the area of teaching modality, cultural knowledge, skill desire, and competence. Constructivist learning theory is a good model for education as it acknowledges multiple socially constructed truths, perspectives, and realities versus a single reality. Developing awareness of differing interpretations among my participants is an important part of professional competence in this country of such a diverse population. One of the basic attributes of constructivism is continually restructuring negotiation, reconciling differences, and continually restructuring thinking and continually restructuring thinking. And the literature I reviewed reflected that ideology. Constructivist education capitalizes on previous experience, multiple perspectives, and opportunities to surround learning in relevant social content. The theory of constructivism validates encouraging personal leadership, values, and accountability. By promoting these measures, we can facilitate the maintenance of academia accreditation teaching requirements and produce students that become the disruptive innovators of the next generation. Reflective observation is one of the qualities of constructivism that embraces independent thinking, autonomy, confidence, and personal satisfaction. This learning model equips the learner to deliver safe and exceptional patient and family-centered care in a safe and supportive environment. Providers are my audience. These learners have a spectrum of knowledge that supports a safe and collaborative learning environment. Constructivism is a very effective and appropriate learning model for medical professionals because we are independent theorists, public servants, and forward thinkers. We remain the cause of why the medical field constantly evolves and improves. This is a slide of my excuse me, my teaching content. So the objective there would be my first objective, and you can read the recognition of the uniform SOAP note as my content. The time allotment was 10 minutes. I did 3 outlines for a total of 30 minutes for this presentation so that it would not take up too much time of a busy provider's schedule. Here's content number 2 with my objective. And you can see again where it was 10 minutes. And content number 3. I used the Likert, the Likert scale for my evaluation to evaluate the content and my performance. The scale was invented by a psychologist, Rensis Likert, and is the most widely used approach for scaling response and survey research. This data should rely on the ordinal nature of data. Here is my evaluation tool. The first 3 questions were geared towards evaluating whether my learners could list at least 3 benefits of using the uniform SOAP note, if they could properly and easily identify a resident problem list at a visit, and if they had been able to identify any increase in resident safety. The rest of the questions were in regards to my presentation, my knowledge base, my rate of presentation, the depth of the information, the audiovisual component, the professional appearance of the speaker. Was the presentation appropriate for the audience? And was the meeting area comfortable? And then I asked for an overall opinion of the content, left them an area for comment, and then finally thanked them for coming and being such a gracious audience. My additional resources were handing out and comparing the mixed formats of what the providers used to do to what the new SOAP note template provides. Hopefully, providers will, at that point, agree this can simplify and organize the documentation to meet the needs of the resident in a safe and efficient way. And here are my references, and thank you very much.